3, 2, 1.
Good evening, everyone. Thank you so much for joining us tonight for our latest Medicine for Member event. My name is Sneha Bedi, and I'm the Royal Free London's lead governor and an elected patient governor. For those of you who are new to our Medicine for Members event, these events are organized and chaired by our Council of Governors. Our Medicine for Members event focus on topics that we know are important to you, our members. These give you the opportunity to hear more about the Royal Free London services. Our topic tonight is Saving Lives, Liver Transplantation at the Royal Free London. The Royal Free London Hospital is one of the 7 specialist liver transplant units in the UK. The team receives referrals and performs transplants for patients across the country. Since starting in 1988, our clinicians have performed over 2,000 liver transplants. Transplantation is a clinical priority for the Royal Free London, and this event will showcase the incredible work being done to help give help to patients with end-stage liver disease a new lease to their lives. Tonight, you will have the chance to hear from 3 specialist liver transplant clinicians, including Professor Douglas Thorburn, Consultant Hepatologist and Divisional Clinical Director for the Liver and Digestive Health Division, Dr. Aileen Marshall, Consultant Hepatologist and Clinical Service Line Lead for Hepatology and Transplant Hepatology, Professor Jörg Pollack, Clinical Lead for HPB Surgery and Liver Transplant. Before I hand over to our presenters, there are just a few housekeeping points that I would like to make you aware of. To ensure that the event runs smoothly, you are set up to view only. This means your camera have been disabled and you have been put on mute. If anyone experiences connection issues or visual problems, this event will be recorded and a recording will be shared with you. There will be a Q&A session after our speakers have presented. We have already received several questions, but if you still want to submit your question, please use the chat functionality on the right-hand side. We will make the best endeavors to answer all your questions, but just in case we haven't, we will get back to you, and please send us your questions on the membership inbox. Now, I would like to also suggest that if you want to contact the Council of Governors with any queries, concerns, or comment, please do email the governors. The inbox is flashing on the screen as we speak. I really hope you enjoy tonight's event, and I will hand over to our first speaker, Professor Doug Thorburn.
Thank you very much, Sneha, for the introduction. It's a pleasure to have the opportunity to present to everyone this evening around liver transplantation. If we go to the next slide, please. I'm going to cover a bit about the general context of liver transplantation in the United Kingdom over the next few minutes. So liver transplantation is an enormous success story in terms of the life-transforming effects of transplantation in terms of extending life and improving quality of life. And within the United Kingdom, we undertake just short of 900 liver transplants per year. So if you look at this graph, you can see the blue lines indicate the number of liver donors there are each year, and the grey lines indicate the number of transplants that are undertaken. And you can see over the last 10 years, there's been an approximate 15% increase in the number of donors. But in fact, overall in the last 10 years, there has been a small decrease in the number of transplants undertaken. And that conceals a much more complicated story. If you look at the year 2021, when we all remember the pandemic, you can see there was a very dramatic reduction in the number of donor and transplants undertaken. And the story of the last 3 years has been the recovery from that, with the increase in the number of donors and increase in the number of transplants. But we have not reached pre-pandemic levels. Can we go to the next slide, please? And as a consequence, I think this slide has been cut off a little, so the numbers aren't so clear. But you can see these are the waiting lists, the number of people waiting for liver transplant in the UK, adult patients and paediatric patients, and as a and children, sorry. And as a consequence of pandemic, so these slides start in 2020, you can see the upward trend in both adults and the number of children that are waiting for a liver transplant. And the waiting list is now over 700 active patients waiting for a liver transplant. And that's the largest waiting list for liver transplant that we've ever had in the UK. And that's been a consequence of the same need, but the reduction in the ability to deliver transplant for patients in recent years. Can we go on to the next slide? And the consequence of that, it has been, well, there's been no increase in the number of deaths in the waiting list or people waiting for a liver transplant. People have had to wait longer. If you just hit the bar, I think there's another line that comes up on the slide, but in effect, all of the waiting times for all of the various blood groups have increased. Overall, there's been an increase in waiting times from 67 days to 120 days overall. And within all of the blood groups, there's been an increase in waiting times, apart from the very rare blood group that is AB. So we've got an unprecedented challenge at the moment with an increased number of people needing a transplant, a reduced number of transplants being undertaken, and patients waiting longer. And I hope with that overview of the national context, I can now hand over to my colleague Aileen Marshall to pick up the presentation. Thank you.
Thank you very much, Doug, for that introduction. So I'm, as Sneha kindly introduced, I'm a hepatologist, which means that I'm a medical doctor, and we and my colleagues look after patients who have liver diseases of all kinds, including liver cirrhosis, acute liver failure. And so I'm going to describe how we assess patients and how the whole team is involved in the process from the beginning of meeting a patient for the first time towards taking them through the transplant, and then as we follow them up. As Sneha mentioned, the Royal Free Programme has been in existence since 1988, and I submitted these slides a few days ago and said that we'd taken under nearly 2,499 transplants. In fact, that number has gone up, and I'm pleased to say that we've crossed the 2,500 milestone. So that's a lovely thing for the whole team and for the hospital. Next slide, please. So again, some statistics. Doug has shown you about the national picture. This is really to do with our local picture. So there are 7 transplant centres in the UK, and in the last financial year, which is April 2022 to the end of March 2023, we undertook a total of 104 liver transplants, which was a slight increase, but again, not back to the number of procedures that we were able to perform before the pandemic. Our own waiting list again is quite large, as with 60 patients waiting on our active waiting list. Next slide, please. Liver transplant is a life-changing treatment. It is a treatment that we give to people who've got a risk of dying from their liver disease, whether that's a long-standing liver disease like cirrhosis or whether a more sudden liver disease like acute liver failure. Overall, the outcomes are very good. So on average, around 93% of our patients are alive and well 1 year later, and 83% are alive 5 years later. So the real goal of our team and all the effort that we put in is to help people have a normal lifespan, but also to live a good quality of life. Next slide, please. So this just illustrates the pathway whereby we hear about patients from a wide variety of referring hospitals across the country. The first step is that we need to meet those patients and have a discussion with them about the assessment process and what they might expect. Once we agree that the patient needs to have a transplant assessment, that takes place here at the Royal Free, and I'll describe what we do there. For the patients who are waiting on the list, we also see them very regularly. And then I'll talk a little bit about the transplant admission and how we follow people up. Next slide, please. So the first thing to say about liver transplant team is it is a very big team, and there are lots of different specialties involved. So when we first meet a patient who's referred from our more local area in North London, we have a weekly clinic which in which a multidisciplinary team of people will see and assess the patients where they need them. People with cirrhosis often have problems with weight loss or muscle loss. They may lose physical strength. They may have other health conditions. And of course, there any other issues that might have caused their liver disease need to be addressed as well. So the first appointment, they will meet the hepatologist, who's my colleague Rachel usually. We have a dietitian, physiotherapist. Our anaesthetists are there to help assess fitness and also to advise on any existing heart conditions or lung conditions. We have specialist nurses in the clinic as well. It is a very stressful and demanding time for patients and their families, and a really important part of the support is given by our liver transplant specialist nurses, who are called liver transplant coordinators, and also our clinical psychologist, who offer regular contact, psychological support to help people deal with all the needs that they have to help manage their ability to cope with the chronic condition and the demands of the treatment. Next slide, please. As well as patients being referred from within North London, we have patients referred from across the country. So we will go out to their local hospitals as a team to see them with usually hepatologists and specialist nurses. And then if need be, the other professionals can be involved remotely. This, for example, I went to Portsmouth yesterday where I saw around 30 patients, and that's really helpful to support the local team and have patients' care delivered to them locally. Next slide, please. So once the patients had their first assessment and we've agreed that they need to be considered for a transplant, we bring them to the hospital for a few days they undertake a series of tests, and also it's really meeting the different members of the team. And the main questions that we're asking are here. So the first of all is the liver disease bad enough to need a transplant? So we'll be looking at how, making sure that we understand what's caused their liver disease, how that's affecting their life in terms of symptom and their quality of life, and also whether they're continuing to deteriorate, because sometimes people's symptoms will fluctuate. They may get better at times, or things may worsen. We spend a lot of time assessing people's fitness, because this is one of the big issues for a lot of patients. So this is where our multidisciplinary team really comes into its own. So we're looking at physical fitness, assessing people's exercise capacity. Our surgeons will be considering all the technical factors, anything that it may cause them difficulty in performing the transplant. We also make sure that people have got enough social support and understand all the issues involved. And then for some patients where alcohol may have played a part in their liver disease, then this also needs to be supported and addressed. And people who are coming forward for a transplant need to be fully abstinent from alcohol and be able to demonstrate a commitment to that lifestyle change. Next slide, please. So this slide just illustrates the different numbers of people that patients will meet over that 2-day assessment. It can be quite a busy time, but we're really fortunate to have the facilities of the day case unit where they can be based while they undertake all these assessments. Next slide, please. Excellent. Thank you. So if you want to have a look at a video which goes through things in a little bit more detail, then one of the national charities, the British Liver Trust, asked us to make a video to help prospective patients and their family understand about the assessment process. And this is Katie Quist, our lead nurse, and some of our team explain this video. So the link is on the slide here. If you're interested, you could have a look at that. It's about 10 minutes long. Next slide, thank you. So then when someone goes on the list, Doug's just mentioned that the waiting times. So some people may be transplanted very quickly. Some people may remain on the waiting list for a year or even 2 years. And it's really important for them that they do their best to remain fit for a transplant, because if they become if they lose their muscles or their strength or their ability to exercise, then there may come a point where they may not be able to have a transplant if they're not well enough. So this again is where our dietitian and physiotherapist really provides a lot of support to patients to help them with their nutrition, to help guide them on exercise, and to ensure that they're able to remain well enough so that when the call for the organ comes, that there's no barriers to proceeding. Again, we spend a lot of time supporting people. It's very stressful to be waiting for something that you know that you need, and yet the call may come at any time. So our psychologist Lucy is a really important part of that team. We also see people regularly in our outreach clinics in the same way that we see them at the beginning. Next slide, thank you. So next step in the process is when the patient receives an offer for a transplant, and the whole system of organ donation and transplantation in the UK is managed nationally. So when someone donates their organs, this is notified to a central hub of NHS Blood and Transplant. The liver transplant waiting list is national, so wherever a patient is in the country, they have an equal chance of getting an organ offer. And when a liver is offered to a patient on our waiting list, we'll be notified. Some livers are suitable to be transplanted and some are not. So this will be discussed with the on-call surgeon and the on-call hepatologist, and we'll agree on whether that the offer is one that we think is appropriate to accept. And once we accept it, the patient will be called into the hospital, and it has to proceed usually within 24 hours, but it may be at any time. Next slide, please. So then this 24-hour-a-day service is something that often people don't get a lot of recognition for, and I just really want to highlight the dedication and commitment of the theatre teams who may be performing transplants at any hour of the day or night. And you see here a picture which includes our surgeons, the theatre nurses, but also there will be many people supporting the team as they're doing the operation, and it is can be a very demanding and long operation, as I'm sure Professor Pollock will explain about. But the dedication and commitment of this team is really important. Next slide, please. So once the operation concludes, patients are taken to the liver intensive care unit, where they'll stay usually for 2 or 3 days before being transferred to the ward. Again, we receive input from the intensive care teams. The surgeon, hepatologist will visit the patients every day, and there will also be input from a wide variety of other specialists. With the liver critical care unit as a separate area in the hospital has been in existence for the last couple of years, and it's been a great benefit to improving the care that the patients receive and the communication between the teams. So we have fixed point in the day where the whole team will meet and have a discussion about each of the transplant patients, so that we're all agreeing the priorities for the day. Next slide, please. So the next step after critical care is that the patients will be transferred to 9 North Ward, and this is our nursing team at handover. We will also have a daily meeting with the doctors, physiotherapists, dietitians, everyone who's involved in their care. And so patients will usually be in hospital for around 2 or 3 weeks, and during that time they'll be assisted in their recovery with any medical issues, and also we take the time to make sure they understand all their medication and the things that they need to do to help themselves in their recovery. Next slide, please. So after patients are transplanted, we will keep keep seeing them lifelong, which will be either at our hospital here or in all the outreach clinics that we visit. The initial recovery is usually within the first few months that we will see people very regularly. And then as time goes by, those appointments will come less frequent. And what we're really hoping to help people achieve is a return to normal activities and normal life. The priorities will be different for everyone, but many people will return to work or to education, to being able to look after their families, to travel, all the things that are very difficult for somebody with liver disease to do. So I think I just have a last couple of slides to show you what life looks like after a transplant. So this is one of our patients who came back to see us a year, and took this photo a year after his transplant. So this is a young man who's been able to return to his work. He's a father of 3 young children. As you can see, he's involved in transplant sports, looking at his hoodie, and is very much enjoying the new lease of life that transplant has afforded him. And next slide, please. In this last picture, you might wonder which of these ladies has had a transplant. In fact, it's both of them. They met on the ward when they were both undergoing transplantation at the same time, and they've kept in touch and again returned to leading really full and active lives. So I think what I really wanted to highlight here is the difference that transplantation can make to people's lives, but also the very wide variety of people and the different skills that are needed to support people through the process. Some of whom we can very easily see as part of the team, but others, such as the theatre teams, who often may not be maybe working behind the scenes, but all of whom are very important. So with that, I will finish. Thank you very much for listening, and I will pass you on to Professor Pollock.
Yeah, thank you so much, Aileen. I shall take you to the operating theatre where I've just come from. So I'm still in Scrubs. I ran up from a liver transplant. Going back into history, so organ transplantation has become established since the early 1950s, when the first kidney transplantation was performed. And the kidney didn't really work for long because we didn't understand too much about immunosuppression and what we need to do to patients in order for the organ to work for a long time. A year later, they tried to transplant kidneys in between identical twins because the idea was that they should share the same immune system, and that actually worked for many years. And since then, we have learned much more about immunosuppression and how we can keep organs in patients working successfully. The first attempts to try liver transplantation was in the early 60s. Tom Starzl in Denver, with quite a few failures over the period until the first really successful transplant happened in 1967 with a function for 13 months, which nowadays would not be a huge success. We've seen that we have 1-year survival rates of in the above 90%. So transplantation has come a long way, and I think transplantation really caught the attention of the general public when the first successful heart transplant happened in South Africa in 1967. Next slide, please. So why can we transplant at all? Because a surgical colleague with the name of Alexis Carrel invented the technique how we can suture blood vessels together, and he was the first surgeon to receive the Nobel Prize. So next slide. So who do we transplant? So patients are either suffering from a chronic liver disease or from acute or fulminant liver failure. So patients who have been pretty well and then suddenly have deteriorated liver function. Next slide. So where do the organs come from? We have seen that there has been a fluctuation in donors. So with almost every successful liver transplantation, there is a sad story towards the beginning, because most frequently a another human being has to die, either from brain death, and this is the initial and still most ongoing form of death in order to become an organ donor, or a more recent development that we can also retrieve organs from donors who have suffered from a controlled cardiac death in hospital. On the other hand, there are more happy stories if we find a living donor who donates a part of their liver for a relative. Next slide, please. So most of these organs from brain death and cardiac death donors arrive after in the donor hospital. These organs have been retrieved and then put in cold storage fluid, and they come in an ice box so that the organ is in an environment of 4 degrees in order to reduce the metabolic activity of the cells so that the lack of oxygen doesn't kill the cells. Then these livers arrive in our center, and next slide. Then we perform the liver transplantation. So the liver is not working well anymore, and it's in a specific location. So unlike for kidney and pancreas transplantation, but like heart and lung transplantation, we have to remove the diseased organ and replace it with the donor organ. And this is a schematic drawing taking you to the operating theater, where a liver has been removed and a new liver has been reconnected to the blood vessels. So the liver is a specific organ, has 2 blood inflow structures and 1 outflow, and produces bile, which needs to be drained through a tube into the gut to help us digesting food. Next slide, please. There's this technique which I showed you, but there's another technique preserving the major blood vessel that runs behind the liver, and that usually gives our anesthetic colleagues a much smoother situation in theaters, because the blood from the lower part of the body can still run back to the heart, and so the heart doesn't have to worry about blood volume coming to it. So that's a dissection, removing the liver from the right side, and the next slide is showing you the same from the left side. And then the liver is being implanted. Next slide, please. So this is then the connection technique when we can preserve the major blood vessel. It's called piggyback technique, and so we side to side rather than end to end connect the major blood vessel behind the liver. Next slide. So we have seen that the usual transplantation is organs arriving in an ice box on cold storage, and then we take them out of the ice box, we connect them to the recipient, and then the liver is being warmed up in the recipient, and in between we have to judge about the quality of the organ on numbers that we receive from the donor. In the recent years, machine perfusion technologies have been developed, and there are some leading centers or leading technology developments that come from the UK. And so we have embraced machine perfusion technology for the benefit of our patients, and we are the only liver transplant center among the 7 in the UK who have access to all 3 different types of machine perfusion. And that allows us to better assess the organ quality before we implant the organ into the liver into the recipient. It can improve the function of the liver, and it allows us to plan the operation much better, to either have a much better environment for the patient in theater if we don't do this during the night but daytime, because everybody is awake and the infrastructure in theater is much more available. Next slide. So I'm now going to take you through the history how we embraced machine perfusion. So there's one type that keeps the liver in a warm environment, like in the body, 37 degrees Celsius, and provides oxygenation to the liver. This we call normothermic machine perfusion, and this is when we started with this device, which was actually developed in the UK from a team at the University of Oxford. We have, among all the machine perfusion technologies, we have performed most of our transplants now with this type of machine. Next slide, please. Machine perfusion can be taken already into the donor hospital and into the donor. So for patients who have suffered a cardiac death, their body can be connected to a machine that continues pumping blood, oxygenated blood, through the organs that we want to retrieve, and that assures much better quality of the transplanted organs, and we can also assess their quality while the organ is still in the donor. And then these livers are being shipped in the usual state in cold storage to our hospital here for implantation. Next slide. The third type of machine, no, we stay with the previous slide. The third type of machine is hypothermic, so cold storage with oxygenated perfusion of the liver, which doesn't really allow too much assessment of the quality, but we know that these organs perform very well after they have been kept in a oxygenated cold phase, and non-blood containing perfusion fluid is pumped through them. This technique doesn't allow us to plan the operation better because you can only keep the liver on this machine for 2 to 4 hours, whilst with a normothermic machine we can stay up to 24 hours and therefore could potentially even accept a few organs and then transplant them after another. Next slide, please. So we developed an algorithm how we could best use our machine perfusion technology for livers that we get on offer. And so the standard pathway is basically going around on the left-hand side. So the liver offer comes from a brain death donor, and it's meant to be a good organ, and we go straight and perform the transplantation. If we are worried about the quality of the organ and we want to assess it, then we bring it to the normothermic machine perfusion and then transplant. If the organ is from a cardiac death donor, then we would prefer to perform the warm machine perfusion in the donor and then go straight to transplant. If that is not available because it's logistically rather challenging, then we would bring the organ here and undertake either normothermic or hypothermic machine perfusion, which can also be the case if we, after NRP, are not sure about the quality of the organ. So we have a tool set available to improve organ quality and to assess the quality of the organ much better than we used to be able to do prior to transplantation for the benefit of our patients. And that also allows us to accept more organs from donors to be transplanted. Next slide. So now machine perfusion not only allows us to do what I've just told you, but it allows us to potentially intervene and improve organ quality, not only assess, improve. And we are part of a clinical trial that is run by Oxford University. And we have been the first team who assessed or tried to improve organ quality on the machine prior to transplantation for organs that have a high content of fat. And we see this in the society more and more frequently. Fatty changes of livers is also a pandemic. Therefore not only we will see more patients with fatty liver disease, but also donors. And this trial is meant to reduce the fat within the liver so that we can improve organ quality. And we have so far assessed a few organs on the machine, and were the first in the world to successfully transplant such an organ into one of our patients. Next slide, please. So what else can we do to increase the number of transplantable organs? So one of the old heroes of liver surgery, Professor Henri Bismuth from Paris, basically said that the liver is a paired organ. It's just grown together, like we have a pair of kidneys. So therefore, invented the idea of cutting through the liver and using two parts of the liver for transplantation. And this is a picture depicted from the harbor of Hamburg, where the first international split course took place. So cut a liver in two to transplant two recipients. Next slide, please. And here you can see a little bit of a schematic drawing of liver anatomy, and there are basically two planes where you can cut through the liver to produce two transplantable livers. The initial one was where you can see 2 and 3. So to take the very left part from an adult liver to transplant a child with that small liver. And then later on, the liver was cut into half much further to the right so that you could potentially transplant 2 adults with one liver from one adult donor. Next slide, please. We have also embraced machine perfusion technology to transplant the extended right liver in the fashion that, especially during COVID, we sometimes had to wait much longer for the patients to be ready in theater. And after the split procedure, these organs have accumulated already a lot of time on the clock, and we can only really successfully transplant them if in between cold perfusion in the donor and connection to the bloodstream in the recipient, the clock has not ticked for longer than 12 hours. So we put an extended right graft as the first in the world onto a normothermic machine and successfully reduced the cold ischemic time by this and transplanted the patient with the liver, which would otherwise have to be discarded because it would have been too long out of the donor. Next slide, please. So I mentioned earlier that living donor liver transplantation is an opportunity beyond taking organs from disease donors. And we embraced this technology in the past, and during COVID, we had a pause and restarted living donor liver transplantation again a few months ago, successfully, with a mother donating half of her liver for her son, and both the donor and the recipient are doing very well after this type of procedure. And there is now a national program in the UK to establish more live donor liver transplant centers to be able to perform this transplantation safely and to increase the number of available donor organs for the increasing demand of patients on the waiting list. Next slide, please. So Aileen already mentioned that we have gone beyond 2,500. I had the pleasure and privilege to be the one who transplanted the 2,500th liver last night, and actually the 2,501st liver during the day, and I basically just came up from theaters after this transplantation. Next slide, please. I just want to take you a little bit into the future, what transplantation might bring us. And this is research that's been undertaken here at the Royal Free and University College London, where a liver that is otherwise not usable for transplantation is being flushed, and all the cells are being removed, and then the liver, which is basically just connective tissue without any cells left behind, is then being recellularized using cells to inject them into the liver. And that might be a possibility in the future to generate more transplantable organs, and potentially even carry the benefit that you could use recipient-owned cells and avoid the necessity for immunosuppression and the risk of rejection of transplanted organs. Next slide, please. So far, liver transplantation can be done for patients with chronic and acute liver disease, and for patients who suffer from a specific cancer inside the liver that derives from the liver cells and is restricted to the liver. But there are now programs being developed in the UK which have been shown to be successful in other countries like Norway, where you can transplant successfully patients, highly selected patients with otherwise inoperable liver metastases from a colon cancer or from a neuroendocrine cancer, or patients who have a cancer within the liver deriving from the bile duct cells within the liver. So there might be opportunities coming up for these type of patients, but highly selected patients who will potentially benefit from a transplantation. In order to avoid the need to allocate the scarce commodity of donor livers to these patients, a technique has been developed to, and next slide please, initially resect part of the liver, which has been done here with on the very left-hand side, then transplant a small component of a liver, next slide, either deriving from a split graft, not reducing the number of transplantable organs for all the patients, or from a living donor with a much lower risk than taking half of a liver from a living donor. Then closing the portal vein, and in the next step, letting the transplanted, next slide please, letting the transplanted component grow so that it's big enough to sustain life of the recipient, and then remove the liver which still carries the tumor burden. Next slide please. Another opportunity might be to create organ assessment and improvement centers. We call them ARC. They have been established for lungs already in the US, and there might be in the future centers like this in the UK specialized on assessing and improving quality of organs on the different types of available organ perfusion technologies. Next slide, please. And I would like to thank you for your attention. And this slide comes, or this little video comes from my old hospital in Hamburg, where heart cells were put onto a scaffold and they really started beating again in culture. And this is just an outlook of what we potentially can do with cell-based technologies in the future. Thank you so much for your attention.
Thanks very much, Jorg. I think you'll come back to me now for to moderate the questioning session. So thanks for that really comprehensive description of the approaches that are being taken to try and meet the gap between demand for liver transplantation and the available supply of organs, and also Aileen for describing the fantastic work of a complex multidisciplinary team working together to deliver excellent outcomes for people that are really in desperate need for help. So we've got a few questions that we've received already, and I think maybe I'll come to Aileen first. A couple of the questions are around what's the future of immunosuppression? Might it be possible for people to take less or even discontinue immunosuppression altogether in the future? And I know you've been involved in some work on this.
Yeah, thank you. So the general principle of immunosuppression is that we try and give the lowest possible doses to achieve no rejection in the organ. And this is highest immediately after the transplant. We need to give a combination of drugs at higher doses, but as time goes by, we will always try and reduce those doses so that people are on the lowest possible dose to minimize the side effects. There is active research into whether it is possible indeed for some people to be able to stop their immunosuppression without experiencing rejection. And so this is only ever done in the context of a clinical trial. And there was a study which was undertaken in most of the UK centres. It was called the LIFT study, or liver immunosuppression free trial, where people were very carefully monitored as their doses were reduced. And that study is yet to complete its follow-up period and publish. And in that study, around about 1 in 3 people who were carefully monitored in that way were able to substantially reduce their immunosuppression, and in some cases to stop it. But for the actual final published details, we have to wait for that. There is another approach being taken in using people's own immune cells that dampen down the immune system. These are called regulatory immune cells, and whether these could be engineered to become tolerant to the donor liver. Again, that's research, and we don't know whether that will be successful as yet, but it's an ongoing project.
Okay, thank you. I think the next question I was going to answer, which was around before patients reach the stage where they've got end-stage liver disease and might need a liver transplant, what can be done for the increasing number of people that have got some form of fatty liver disease? And it's estimated that about 30% of the population may have fatty liver disease. That's part of a syndrome where people have high blood pressure, diabetes, are overweight. We've already developed pathways with our colleagues in primary care for the early detection of liver disease. We've got a so-called Camden and Islington pathway for abnormal liver function tests that you can find on the internet, and that's all about early detection of people that have abnormal liver function tests and liver tests and work them up in a standardized way to identify within them those people that have significant liver disease and need something done. The vast majority of people will just have some degree of fatty change in their liver, and if focused lifestyle change with weight reduction, increased exercise, low fat diet is undertaken, weight loss of 8 to 10%, it's possible to reverse the liver condition. So we've already got those pathways in primary care, and with the development of the new community diagnostic centres, there should be other options that we will have to try and increase our capacity and our ability to detect early those people that have liver disease and fatty liver disease in addition. So the next question maybe come to you, Jorg. What does the future look like for the liver unit at the Royal Free? Maybe Aileen would want to comment as well, but quite a broad question, but I think you've got lots of ideas, so take it away.
Yeah, so I think the future to a certain extent has already started with us embracing machine perfusion technology hugely, with being actively involved in improving machine perfusion technology to make the good use of more organs and to avoid transplanting organs that are not working very well into our patients. Yeah, we are developing the surgical team and as well as the hepatology team further to provide superb quality of patient care, and this in conjunction with patient advocates and patients who have been working with us on improving our pathways.
Okay, thank you very much, Jorg. Is there anything you'd like to add to that, Aileen?
Yes, I think the hospital has a sort of 3 tripartite mission where we want to be excellent in clinical care, research and teaching. And I think we see all of those things as being important in developing in the future. I think just to focus on the clinical service, the liver unit, we're talking about transplant, but transplant's really the tip of the iceberg. There's a great many more people with liver diseases and with undetected liver disease that we need to make more efforts to be able to diagnose early and therefore to prevent people from progressing to the more serious forms of liver disease, as well as for those people in whom we can't, there are various diseases that we can't change at the moment, that will still need transplant. So it's yes, I think just a very broad and expanding focus on early detection, excellence in teaching and clinical care, expanding the multidisciplinary team and the contribution that specialist nurses, physiotherapists, pharmacists, everyone can make in improving the quality of care is something that we're very interested in developing too.
Thanks very much, Aileen. I mean, we do have to acknowledge, I think, a good opportunity to acknowledge that we're kind of standing on the shoulders of giants here, because the liver unit at the Royal Free was one of the very first liver units in the world, and that was based on the vision of a lady called Dame Sheila Sherlock, who was the first female professor of medicine in the United Kingdom, and set up the liver unit over 60 years ago, when she moved to the Royal Free Hospital from the Hammersmith to become a consultant. So there's a very long tradition of liver disease interest at the Royal Free Hospital, and it was always from the very beginning based on those three principles of clinical care, and they were really learning how to care for patients with liver disease at that point. But that was based on research, learning from the care that was being provided, and the education and development of young colleagues, whether they are doctors, nurses, physiotherapists, etc. And that's a long-held tradition that's continued to this day within the unit. So I think from my perspective, the future remains bright for us, and you've already heard about a number of the research initiatives that are taking place to try and drive forward the care of patients with liver disease, both surgically and medically. There's a question here about how can people find out more about research into liver treatment and care. Would anyone like to take that, Aileen or Georg? I would, maybe before I hand over, there is an organisation called the British Liver Trust, which is the largest liver charity patient support group for liver disease, and they've got excellent information about liver disease, and also would be able to direct you to people nationally that might be involved in research. If you're interested in finding out what's happening here or in what way we can help you, I expect there's a means of contacting us at the end of this, or by all means write to one of us, the speakers, and we'd be very happy to help and direct you to any help or information that would be of assistance to you. The other question that we've got here is, I think for you, Georg, which is, have the risks for living liver donation donors reduced?
Yes. Can you? Yeah.
Yes.
So yeah. So I had the privilege of working in the first European live donor unit in the early 90s, and I had, unfortunately, the situation that in my very young years I was witness to the first death of a donor. So donor safety has been my utmost concern in my professional career, and that is shared by the community. Yes, the operations and the procedures, everything around it have become much more safe, and we will do everything to reduce the potential risks and make this a very safe journey for the donor.
Thank you very much, Georg. I think there may be one final question before I hand back to Sneha. And this is from a patient who's had treatment here, and they're wondering about whether cell therapies where the person might be treated with their own cells to reduce the risk of rejection might be a feasible form of treatment for them in the future. Would anyone wish to comment on that?
I can comment on that.
Aileen, thank you.
Yeah, so I alluded to a study which is looking at taking people's own immune cells that dampen down the immune system. They're called regulatory cells, and whether they can be engineered to become tolerant to the donor organ. So there is a study just open that is doing that. It is only at the present time suitable for people of a particular cell type, because the cell has to be engineered against that cell type. And we are approaching people of that particular cell type to see if they can take part in the study. In the future, then other cell types may be the focus of research. So the answer is potentially yes, but only in the context of a research study. Hope that's helpful.
Thanks very much, Aileen. So I think at this point we've gone through the questions that we've received. I see one request to see if these meetings could be face-to-face in the future, and I'm sure everyone would enjoy that but we hope we've provided you an interesting insight into liver disease and the use of liver transplant to treat patients with liver disease. And with that, I'll hand back to Sneha. Thanks very much for listening.
Firstly, thank you so much to our clinicians and speakers for such detailed presentation and a great Q&A. It was very insightful and informative, so big thank you. I would also like to share that on the 31st of October at 6:15 p.m, we are hosting an in-person annual members meeting. On the annual members meeting, we shared about trust achievements while recognizing our challenges we faced throughout the year, sharing the operational and financial performances report, as well as making sure that we share the brilliant work that we are doing with our partners to make a difference in our community. We will be sharing all these details in an email. You'll be receiving an email shortly by next week, and the details will be updated on the website as well. So please do sign up for the event. If you have any questions, do email to the governor's inbox. And once again, I would really like to say thank you to our presenters today for such an insightful for such an insightful event. Thank you all for attending. A big thank you from us.